Women's Health Weekly here from New York City. Experts from Maiden Lane Medical, New York City, around the country and around the world. We're here today with Dr. Carol Long-Roche, who is a gynecologic oncologist, expert in gynecologic oncology, HPV, pap smears, and everything associated with it, who is at Memorial Sloan Kettering Cancer Center. So if I'm a woman and I've been diagnosed with cervical dysplasia, what do I do? Should I be worried? Should what's the skinny on that?
Cervical dysplasia can be mild, moderate, or severe. And depending on the situation, the age of the patient, their desires for, fertility, as well as the type of cervical dysplasia, in some cases with low-grade cervical dysplasia or mild cervical dysplasia, you can just continue to observe. But for higher grade cervical dysplasia, very often a excisional biopsy is needed. And that is what I referenced earlier, where a portion of the cervix, a small portion in many cases, is excised to remove those abnormal cells and also to give the pathologist a little more tissue to examine to make sure that there's no cancer.
Are there any potentially complementary or alternative therapies that have some level of efficacy?
So we do have some, there is some evidence that using the HPV vaccination can help to treat cervical dysplasia. Many times that's done in the setting of a small excisional biopsy, and then the vaccine is given, and that increases the chances that it doesn't come back. There was a study done that looked at the use of a newer vaccine that's not out on the market to actually treat these lesions. And instead of doing an excisional biopsy, that is still in the experimental phase. There are some other techniques like ablations. As an oncologist, I don't use those as often because for us, excision and getting pathology is really an integral part of the care. And there are some select situations in which moderate cervical dysplasia can be observed and very closely, and to see if it can regress on its own. And like with anything, patient autonomy is key, and patients need to hear the risks and benefits of all of their choices. And, if a patient chooses to do something that isn't what we recommend, we can still support them through that and make a good treatment plan. But of course, it's our job to present the facts.
If I'm a woman talking to my gynecologist about whether or not to do this procedure, what the issues are there any critical questions that I should be asking my gynecologist?
If there is a dysplasia diagnosis and the next steps are being discussed, I think, first of all, the desire for future pregnancies needs to be a huge part of the conversation. And I also think, risk benefits in weighing the long term. I mean, there are women who have completed childbearing who might be having multiple colposcopies and pap smears and excisional biopsy recommendations, and they may choose to have a hysterectomy and remove the uterus and cervix altogether because that risk may be lower to them than the ongoing stress of the surveillance. To other patients, they want to keep their uterus and cervix, and so they would prefer to go that route. So I think just really understanding a patient's values and goals and what's important to them and what risks and they are willing to tolerate is really the most important part. So I just think an open dialogue is the best.
So you mentioned earlier resources, and you mentioned that there are places where patients don't necessarily have access to the wonderful system and the wonderful physicians and technologies and techniques that we have here. New York City for one, but certainly there may be other parts of the U.S. where those resources aren't available. Let's talk about some of that either those health disparities that are associated with either lower income areas or countries that are not as well off.
Yeah, I think that certainly in terms of the planet, there are countries that don't have access to regular pap smears, to gynecologists and gynecologic oncologists and procedures. However, interestingly, some of those countries are actually doing better than we are with HPV vaccinations. Rwanda is an amazing example. They used a community health worker strategy to increase the vaccination rates, and they have increased their HPV vaccination rate in girls to 93% of the population. And so we expect to see a drastic decline in cervical cancer there. Interestingly, they don't give the HPV vaccine as readily there to boys because they don't have access to it like we do. They need to save it for the girls. Other countries like Australia has really done a great job of getting HPV vaccines out. I think in the US, we have a lot more fear about vaccines, and that's limited us, even though we actually have ready access to it.
Sure.
But we do still see disparities even within our country, socioeconomic status and racial disparities that we as providers need to make more efforts to overcome. I think that there, unfortunately, is a loss of trust. Probably some is valid, but some of it maybe is just people have had bad experiences. And so we need to regain trust, and we need to increase access to healthcare and access to these strategies that can keep people healthy.
This has been Women's Health Weekly from New York City with Dr. Carol Long-Roche from Memorial Sloan Kettering Cancer Center. Please subscribe to our YouTube channel. Don't forget about our podcast. Next week we're doing a total 180 next week. We haven't decided it's either natural beauty products or we're going to do weight loss and nutrition and a revisit on that. Once again, thank you, Dr. Long-Roche, for your time. I wish everybody a wonderful, healthy, and safe, and hopefully somewhat dry weekend. Thank you very much, and God bless all.